amount of insulin, even when we're not eating. You need some insulin to restrain the hepatic glucose production. Otherwise, you will get fasting hyperglycemia. But you get these large increments of insulin occurring very rapidly whenever you ingest food, as illustrated on this slide. Okay, so you can think of, if you like, in someone who's taking 3 meals a day, you can think of a sort of basal insulin secretion, which is represented along the bottom of this slide by the lower line of the box that has been put in, and then the mealtime insulin represented by the arrows. Adi showed earlier that in type 2 diabetes, you do tend to get a rather steady decline in beta cell function after the diabetes has been diagnosed. Of course, our common practice tells us, our common experience tells us that not everyone declines in their beta cell function at the same rate as everyone else, and I've got many patients who have never needed insulin during their life with type 2 diabetes, and I have other patients who have required insulin rather soon after being diagnosed with type 2 diabetes. It's worthwhile remembering that a proportion of patients who are diagnosed with type 2 diabetes actually turn out to have latent autoimmune diabetes. And if you're not getting this, I think is a good learning point. If you're not getting good control, the sort of control that you would expect to get with 1 or 2 oral agents, think of the possibility that you might be dealing with a patient who has latent type 1 diabetes. It's more common than people realize, certainly in America and in Western Europe, and I suspect that the figures would not be that dissimilar here. So, initially, if we are going to give insulin treatment in type 2 diabetes, basal insulin replacement, taking care of that background level, is relatively simple and may make sense. But as insulin deficiency becomes more advanced in type 2 diabetes, then you may find that there are patients who are going to need both basal insulin and mealtime insulin replacement. I'm not saying that basal insulin is the only way that you can introduce insulin treatment in type 2 diabetes, but it is a simple and logical way to do so, and I hope I will show that. This just shows you the profiles of the different insulins which are available and the insulin analogues. Nowadays, we have, I should really put, as well as glargine, I should put levomir into, or insulin detamir into this as well. We have 2 insulins which are effectively basal. Peakless insulins can be given once a day. Levomir sometimes needs to be given twice a day. Before these insulins were introduced, NPH insulin was effectively the most commonly used so-called basal insulin. And I will show you some data which I think shows that it can still be used, and of course it is less expensive than the newer insulins. In terms of mealtime insulins, you will see that regular insulin, which was the only mealtime insulin which was available when I got interested in endocrinology back in the 1970s, that actually has a peak of action which, you know, doesn't occur until an hour or 2 after you've taken the injection. And most of my patients, if they need mealtime insulin, they get up in the morning and they may be running late for work. They're not going to give their injection and sit around for 45 minutes before taking their breakfast. This is a pipe dream. So the development of the designer insulins, the more rapidly acting insulin analogues, Lispro, Aspart, and glulisine, which have a peak action within about 60 minutes and effectively are cleared and not having much action beyond 3 or 4 hours have really become the closest that we can mimic to that mealtime surge in insulin if we're using insulin injections. Concerns about insulin therapy. Be aware, of course, that in type 2 diabetes, once you introduce insulin, you incrementally increase the risk of hypoglycemia. Insulin trumps any of the other anti-hyperglycemic drugs in terms of its potential for causing hypoglycemia. But in contradistinction to type 1 diabetes, the use of insulin in people with type 2 diabetes, particularly if you're just using basal insulin, is not anything like as likely to cause really severe hypoglycemia. So I don't think the fear of hypoglycemia should be a deterrent to the appropriate use of insulin in type 2 diabetes. Worsening atherosclerosis. There have been some studies going way back to the 1960s suggesting that hyperinsulinism and perhaps insulin treatment itself could possibly lead to a worsening of atherosclerosis. But I don't think people really believe that nowadays. And there have been, for example, the UK PDS showed that the patients who, right from the start of their diabetes, who were randomized to insulin treatment have not been any more likely to develop atherosclerotic disease than patients randomized to get other treatments. The biggest barrier to insulin treatment, and I'm talking about in America, is that patients tend to perceive insulin as something to be avoided or in some way a defeat that they've let themselves down by not being able to treat their diabetes without having to resort to insulin, or some of them regard it as the end of the road. Lots of people, because type 2 diabetes does occur in families and there has a strong genetic element, many patients with type 2 diabetes know elderly relatives who seem to be just fine and dandy until some lunatic doctor put them on insulin, and then 6 months later they start losing their feet. And they put 2 and 2 together and discover that it adds up to 5 because they think the insulin caused the bad outcome, whereas not getting insulin sooner probably was more important in determining that bad outcome. This is from the UK PDS showing that monotherapy, be it with sulfonylurea or metformin or insulin, rarely is effective over the long term if we're looking simply in terms of maintaining an A1C of less than 7%. So here are principles of therapy: diet plus exercise plus metformin. Then you have options: give a second oral agent. You could then go on to a third oral agent, or you could go on to a second oral agent plus insulin, or 2 oral agents plus exenatide. I made this slide some while ago when inhaled insulin had been introduced in America, not now available. So what is the rationale for basal insulin therapy? Well, it resides in this slide, I would put to you. If you look at the left-hand side, the blue dotted line shows the pattern of glucose over a 24-hour period in someone who does not have diabetes. You can see it's quite strictly confined between limits of no less or no lower than about 70, no higher than about 140, with little peaks after meals. If you look at the upper line, this is someone with type 2 diabetes. And the thing to notice here is that the line is not too dissimilar. There still are peaks in blood glucose after meals, but the most, and you will see that, and this is someone who would have been early on in their type 2 diabetes, that after